Hello, this is Nathan Radcliffe, and I'm really thrilled to be here speaking with you all virtually about some glaucoma vital signs you may be missing and how to take a look at glaucoma from a slightly different perspective than we have been since the beginning. I'm going to go over what we have on the table in terms of looking at glaucoma in 2021, what another diagnostic helps us do in glaucoma, and my journey with a enigmatic factor called corneal hysteresis. And, I want to explain what hysteresis is, go over some papers, show a few cases, and then talk about corneal biomechanics. And I want to let you know I'm not an engineer and I don't consider myself particularly smart. So if I could wrap my head around hysteresis, I think just about anyone can, and that's my goal. Help you leave this talk with a good sense of not only just what it is, what we're really talking about, but how I can use this to better take care of patients. Little personal note, I diagnosed my mother with glaucoma many years ago when I was in training. And actually, it's probably partially why I became a glaucoma specialist. And interestingly, when we checked my mother's hysteresis, it was incredibly outside of the normal limits. And, if we'd had that value a long time ago, we would have really gotten ahead of things. So, let's start with what is hysteresis. And you've probably heard this term, biomechanical property. Corneal hysteresis is a behavior. And let's look at these shock absorbers. Okay, on the left, we have a good shock absorber. And on the right, we have a bad one. And what does the bad shock absorber do? Well, it moves too much. It doesn't absorb the blow. And the experience of being on a vehicle with a bad shock absorber is that as the passenger, you experience more stress, more trauma. So a shock absorber can absorb blows, protecting another part of the vehicle, in this case, and make for a smoother ride. If we move towards thinking of the eye itself or even the cornea as a shock absorber, you could imagine that you want the eye to be able to absorb some blows. And that if the eye is good at handling stress, it might be safer for really important parts of the eye, like the optic nerve. And one other thing I would tell you is that if you're riding down the road in a car with really good shock absorbers, and someone says, hey, how big was that pothole we just rode over? If your car is really good at absorbing shocks, you might say, did we go over a pothole? So there can be some way in which having a good shock absorber makes it kind of tough to even tell if some shocks or stresses are being placed on the eye. Go over that in a variety of ways, but just sort of keep that in the back of your eye. And I don't, particularly use the term, elasticity and viscosity, but one is the sense of a spring and the other is a shock absorber, a dampener, and that's what the viscosity does. So let's sort of see how that's going to fit into corneal hysteresis. I'll also say that throughout this talk, you're going to hear analogies between corneal thickness and hysteresis, because hysteresis is, in my mind, sort of what we always meant when we talked about corneal thickness. So hysteresis, unlike corneal thickness, isn't a static behavior, isn't a static property. I mean, your corneal thickness is what it is. You can use a ruler to measure it. Corneal hysteresis is a behavior of the eye in how it absorbs and dissipates energy. It's not quite an indication of stiffness or rigidity from a biomechanical sense. And do keep in mind that the eye is under constant assault. You may have heard things like the pressure goes up to 60 millimeters every time you blink. And the ocular pulse is constantly entering the eye and pushing energy into it. David Luce pioneered corneal hysteresis, worked at Reichert, and I think Reichert is up to, gosh, I want to say 200 years here, but Dave Taylor will correct me. So 188th anniversary yesterday for Reichert, which began as American Optical. And David Luce, a fascinating guy and an engineer, worked on airjet tonometry and noticed the hysteresis signal, and is the reason we're all here today. The hysteresis signal came from airjet tonometry, and what you see here is, this is how we do airjet applanation. We have an infrared sensor on the eye. We put a puff of air in. We measure the deflection of the cornea. And it turns out the cornea does two things when you put an air pulse on it. It bends in at one pressure and it bends out at a second pressure that is usually different from the first. That difference between the pressure at which the cornea bends in and out is the hysteresis. So if you want a concrete, how's the sausage made definition of hysteresis, it's the difference between the pressure at which the cornea bends in and the pressure at which it bends out as a jet of air is being ramped up and then back down. If you think about it, the fact that you indent at one pressure and then, return to normal at a second pressure is telling you that the cornea is absorbing some energy in that process. And that's really what we mean when we say things like shock absorber. So getting again to some sort of nuts and bolts, if you look at the ocular response analyzer, which is the only instrument that can measure corneal hysteresis, the ocular response analyzer puts out a few variables for you. And I'll just go over those. So the first one is something called IOPcc. It's the Goldman equivalent pressure. This is an air jet pressure, just like you would use if someone said, what's the patient's pressure today? It's designed to be correlated to Goldman, which means like Goldman, is a little bit inaccurate. What I mean by that is Goldman tonometry, we all know, is really dependent on corneal thickness, and IOPcc has all of Goldman's strengths and weaknesses. On the plus side, if you were to obtain an ocular response analyzer and throw out every Goldman in your office, I will tell you, you would be able to practice just as well using only the IOPcc value from the Reichert with no problem moving back and forth. And in fact, I now have one office that is entirely using the ocular response, actually two, that's entirely using the ocular response analyzer. We don't check Goldman anymore. Do I have the ability that I use once every 2 months because something just doesn't seem right and I double check? Sure, yeah. But I make it through many, many days with many, many patients, never guessing that the ocular response analyzer is anything but perfect. I like it because it's objective, and the ocular response analyzer ain't having a bad day. It's never in a rush, and it never checks a pressure and says, I don't care whether it's 10 or 12, I'll just write 12. The ocular response analyzer gives you inaccurate information. So it also measures corneal hysteresis, which we'll be talking about, and it actually even takes that hysteresis value and adjusts the Goldman pressure for something called corneal compensated intraocular pressure. Just as you may have said, let me adjust this patient's Goldman tonometry for their thick cornea and take off 4 millimeters. Corneal compensated intraocular pressure is a similar thing, taking away that hysteresis impact and giving you what the machine thinks is probably the pressure inside the eye after subtracting the shenanigans induced by corneal hysteresis. And shenanigans is the technical term. But it really is because, it's something you can't see that's messing with the accuracy of your measurements. And so we have to measure it in order to make adjustments and in order to interpret the patient's pressure accordingly. The machine also gives you a waveform signal, which is a 0 to 10 value on how quality the score is. And if you want a good example of what waveform score is, it's just like the OCT, Cirrus OCT signal strength. It's not that a 6 is a fail. It's still a very useful OCT. It's just, not as crisp a signal as you get when it's a 10. So, I use OCTs with waveform scores of 4, but I keep in mind the signal strength is a little low. Same with waveform score. There's no rigid cutoff. So where did the fascination with corneal hysteresis and glaucoma all begin? And I would point you to a gentleman by the name of Harry Quigley and Nathan Condon, two at Wilmer. And actually, interestingly, Devinder Grover, who's now a glaucoma rock star, was also on this paper dating way back to 2006 as a medical student. They took 230 glaucoma patients and just said, what would have told us if we looked back now that they were at risk of progressing? And interestingly, they were the first to report that a low corneal hysteresis was one of the strongest indicators that people progressed years later. What else was older age and the fact that they needed treatment, which meant that Quigley and Condon were able to identify people with bad glaucoma. And they were sort of able to show that the combination of having a high pressure and needing treatment was a good indicator. But hysteresis really emerged as the strongest one in this study. And so interestingly, corneal thickness wasn't. And this is something we see time and time again. In this next study, corneal hysteresis was looked at in normal tension glaucoma. Now, why are we instantly fascinated with corneal hysteresis and normal tension glaucoma? Because normal tension glaucoma is the one disease where the pressure doesn't seem to have all the answers. And the first question that came to my mind was, well, maybe the pressure is high and the cornea, because of its biomechanical properties, just isn't showing us that story. And indeed, when you look at normal tension glaucoma patients, it is in fact their corneal hysteresis that is going to indicate they're at a higher likelihood of progressing. So if you take one thing away from this talk, it is that people with a low hysteresis are more likely to have glaucoma. So if you have a pool of glaucoma suspects and hysteresis is low in some of them, they're more likely to develop glaucoma. And if you have normal tension glaucoma or normal, just regular run-of-the-mill glaucoma, a low hysteresis is a risk factor for progressing. And just to get a little bit ahead of myself, I'm going to tell you that just like corneal thickness, it's probably both a risk factor because the pressure is really higher than we measure, but also independently a risk factor regardless of the pressure. So low hysteresis, you're more likely to progress. In fact, you know, the low hysteresis group 2/3 progress compared to only 1/3 of those with a higher hysteresis. So hysteresis is in fact a prognostic indicator, and this beautiful study by Medeiros here really plays it out very nicely. This was the, I think it was the DIG study, Diagnostic Innovations in Glaucoma study, prospective UCSD study that has been looking at glaucoma, following people, some treated, some not treated, some suspects. And basically, when they separated patients with a hysteresis above 10 and below 10, they found there were no rapid progressors in patients with a high hysteresis. And as you can see, many rapid progressors with an average slope that was quite negative in those with a hysteresis below 10. And in fact, hysteresis was 3 times more associated with a worsening visual field than corneal thickness. And so, you know, you have a complex relationship there. And in fact, if you had both a high pressure and a low hysteresis, that was the worst combination, and resulting in this kind of map. And I'll reference this map a few times, but who was the worst off? Well, bottom line, someone with a low hysteresis of 5 and a pressure of 25. But note that if you had that same pressure of 25 and your hysteresis was 10, you're really less likely to be progressing, almost negligible amount of progression. So we have the effective pressures dependent upon hysteresis, I think is a great way to put it. This study was then shown to be very similar for just glaucoma suspects, and this is a survival curve here, showing your probability of developing glaucoma over 5 years. And you see that those with the low hysteresis are going on to develop glaucoma at about double or maybe even a little more the risk of those in the low hysteresis group. So let me just give you a quick bullet point here on how you can sort of bring this into the clinic Monday morning. Let's say you have a glaucoma suspect and one of their eyes looks really suspicious to you, the other looks a little better. And you take that patient, you measure their corneal hysteresis, and indeed the eye with the suspicious OCT also has a lower hysteresis, and it's 7. And the eye with the better looking OCT has a hysteresis of 12 or 11 or 10. That's an indication that you have 2 independent abnormal findings in an eye that you're already suspicious for one reason or another has glaucoma. Things like that can lead me to initiate therapy. And because of this data showing that glaucoma suspects with low hysteresis are more likely to convert. So again, it's sort of like the Oates risk calculator and the impact of corneal thickness on glaucoma risk, but on steroids, because the effect is more powerful when you're using hysteresis. And that's the other way to look at this, is that in every study where hysteresis and thickness have been compared, including these two Weinrev studies, hysteresis was more powerful. So in theory, you get the ocular response analyzer and you can give up your pachymeter, and you can also give up your Goldman tonometer. You know, it sounds crazy, I know, but it's true. It's the data. So, you know, we follow the data, and you know, I hope you share my my kind of bewilderment and amazement that this factor can be so powerful. Now, let me show you my study here with a few of my colleagues. Josh Ehrlich is now at the University of Michigan doing some incredible, you know, biostatistics. He's really built a great career for himself. But what we did is we took about you know, 60 or 70 patients that I had treated for glaucoma in my clinic. And we had baseline hysteresis and then a second hysteresis about 6 weeks after they had started treatment. And I do recommend repeating hysteresis from time to see how it changes, particularly if you change therapy. And in this study, what we found is that if you had a low hysteresis, and I put you on latanoprost and Lumigan, something like that, you would experience about a 30% pressure decrease. But if you were in the highest hysteresis group, with a hysteresis around 12, you showed very little pressure change when you were started on a prostaglandin analog, 7.6%. Now, I think most of us would call someone who gets 7.6% pressure reduction a non-responder. And this to me opened up a lot of thoughts, and I'll just share some of them with you. Number one is that eyes that have, and now look at the baseline pressure was really never that high in any of these, but you know, even with the low hysteresis group, the baseline pressure was only 19.4. But if the hysteresis is low, the eye is almost telling you that it is a spring that needs to be sprung. And when you put that drop on, there is a huge pressure relief to be gained. And what is telling you that the eye was under pressure and under stress, and that its shock absorber was stressed and not working very well? The hysteresis of 7. So you get this huge release of pressure from the prostaglandin analog because the eye was stressed. In an eye with a higher hysteresis, the eye is sort of telling you, you know what, I'm not, my load isn't that high, I'm not under tremendous biomechanical stress, and you put them on a drop and the eye sort of comes down a little bit, but nothing crazy. That's one way to look at it, and I think that that explanation is accurate. But there's also another, which is that in eyes with a high hysteresis, so much of the Goldman applanation is being absorbed when you try to applanate with Goldman tonometry, that you just don't see much pressure change when the drop works, even if the drop's working. So think of it as an eye with a high hysteresis, the cornea can kind of hide pressure changes from you. And in an eye with a low hysteresis, you're more likely to get accurate assessments of pressure. I was able to follow this up with a study looking at IOP fluctuation. I don't have it in this deck, but suffice it to say, we found there was fluctuation in eyes with low hysteresis. And in eyes with high hysteresis, you see less pressure fluctuation because that hysteresis is kind of confounding the pressure at every visit. Even if the pressure goes up and down a little bit, you may not see it as well because the shock absorption of that cornea with the high hysteresis is so good. Every single you know, person who kind of sits down for a moment and thinks deeply about this will ultimately come to the conclusion that there's got to be a relationship between the optic nerve and corneal hysteresis. And we don't have this paper in the deck either, but you know, I had a study where we showed that you could see optic nerve cupping in serial fundus photos more easily in eyes with a low hysteresis. And I'm thinking, I can't believe hysteresis is measured with the Riker machine is predicting what my fundus photos are going to tell someone who knows nothing else about the patient, is just looking at fundus photos. And what you end up seeing is that in eyes with a lower hysteresis, you're going to see more change in this study, it's a little complicated, but in this study, in eyes with higher hysteresis, you saw a change, a big movement forward in the lamina when the pressure was reduced. And the reason, again, is if the back of the eye is a shock absorber, then when the pressure goes up, the nerve will actually accommodate that pressure rise. So think about, again, young kids tend to have high hysteresis. What happens when their pressure goes up to 40? They develop 0.8 cups. What happens when their pressure goes back down? Their cupping goes away. That is a high hysteresis behavior. Their eye is accommodating the high pressure by stretching. And then think about what happens when you get older, you lose your hysteresis, it's now low, the shock absorber isn't working, the pressure goes up, but your hysteresis is low. Instead, the nerve can't cup in a physiologic manner, and you probably have retinal nerve fiber layer stress and damage across the lamina. So it's a healthy behavior for physiologic kind of cupping to happen, like in young kids with a high hysteresis. And maybe when we get older and we lose that shock absorber capacity is when ganglion cells start getting damaged. All right, well, I have some cases here. Let's look at Felipe Medeiros provided this case for us. So this is a 62-year-old man with the diagnosis of primary open-angle glaucoma, and currently on maximum tolerated medical therapy and having undergone a couple sessions of laser trabeculoplasty. So that's saying quite something. The patient's on 2, 3, 4 drops, has had laser trabeculoplasty twice, young man, 20/20 vision, normal eye exam. Goldman pressures are 10 to 12. Okay. Corneal thickness is 545 versus 541. So pretty much average cornea, particularly in a glaucoma clinic. And what do we see from 2003 to 2011? We see a mean deviation go from -8 to -16. We see the VFI go from 63 down to 45. We see some nerve changes with just increased cupping. Particularly, I see that pretty clearly in the superior neuroretinal rim. And we're having progression despite low pressures and normal corneal thickness. And hysteresis is measured, and it is found to be 6.1. That's very low. Just to, again, you're kind of hearing some of these numbers for the first time. 10 is certainly normal. 9 to me is borderline. 8 is low. I hear often 9 being low, and in a technical sense, it's a little low. But is 19 a high pressure? It's still within normal range. So these are just kind of general guidelines. So remember, I told you that the patient had a pressure of 10 to 12, but the hysteresis being 6 is your red flag there. And I always use this analogy, that someone could have a pressure of 30 and a cornea thickness of 600, and you might get nervous about that patient, but you shouldn't. What would make you more nervous is someone with a pressure of 20 and a corneal thickness of 500. It sounds crazy, but that person, the pressure 20 with a corneal thickness of 500, has double the risk of the guy with the pressure of 30 and the corneal thickness of 600. And just like that, when you heard 10 to 12 here for the pressures, you probably breathed a sigh of relief. And in fact, the corneal hysteresis 6.1 was the red flag. Now, what does that tell us to do? It's a great question. I'm going to skip that map for now, but it basically tells us that we should sort of think of everything we can do for this patient, and it might have told us this patient was going to progress. Would I do a trabeculectomy on this patient just when I measured the 6? No, but here's something you could do. You could check visual fields more frequently. So I might have said to this person, let's play Monday morning quarterback, it's 2003. Hey, you have a real red flag here with this low hysteresis and your pressures are good, but I'd like to check visual fields every 4 months. What does that do for me? It helps me catch this reasonably rapid progression in 2005 instead of 2000, 7, 8. So, you may, and I think that, if Justin Schweitzer were here, he'd probably say that just as often hysteresis helps him increase testing frequency, take another look at things, repeat an OCT, repeat a field, kind of management things as much as treatment, because I'm not going to get a hysteresis of 6.1 and schedule a trabeculectomy the next day. But I might start to put myself in a position where if things play out the way I suspect they will based on hysteresis, I will have all the clinical evidence I need to do surgery going forward. So that's the the sense there. We did get an audience question I thought I'd jump over to, which is, do you believe hysteresis is more important than corneal thickness? And I do, and I recognize that you're probably not going to get rid of your DGH pachymeter at this point in time. You need it for your cornea patients and all that. I get a corneal thickness on every biometry before cataract surgery. I still always kind of take a look at that number. And I think at some point it'd be almost tough for my brain to stop looking at corneal thickness. But if I have a patient where the hysteresis and the thickness are kind of disagreeing with each other, I go with the hysteresis. That's the key, is to just have faith. Just like there's probably a day when you saw someone in clinic 10 years ago and their corneal thickness was 620 and you let them walk out with a pressure of 24 and you kind of felt uncomfortable. But you knew based on the OATS study that this was a safe thing to do. And it's just the same. So, you can trust the hysteresis. All right, so let's look at the next case. It's a 73-year-old Caucasian female diagnosed with ocular hypertension, and 3 years ago by an outside provider. Sister's being followed for glaucoma, not treated, on Bistolic, pravastatin. Statins may be neuroprotective. There was a study designed to answer that question and didn't get funded 3 or 4 years ago. We'll see if that one gets back on. It's called the STOP study. Latanoprost at bedtime is the medication. The base pressure was 26 down to 25. And by the way, the second I see that they only got a 5 millimeter pressure drop from latanoprost, I ask myself if they have a high hysteresis, and it turns out they do, 11.6 and 12.3. Corneal thickness, again, is a little on the thick side. Healthy RNFL, 0.6 nerve, no disc heme or beta zone atrophy. What do we think about this patient? And I see this all the time from my colleagues, maybe who don't have hysteresis, and a lot of them want to add another drop to that patient who couldn't get their pressure below 21. They're thinking, I don't get it. Latanoprost should have brought them down more. Maybe this means their glaucoma is more serious. And one thing I always step back and say, your ability to get the pressure down and the seriousness of their glaucoma are often two different things. Again, I look to the nerve to see how serious the glaucoma is, and the pressure is often telling us just as much about the cornea as it is about anything else. So we look at this patient, non-responder, high hysteresis, full field, good looking OCT, and good signal strength. Everything's looking good. There's two ways to look at this patient. So when you look at where they fit on the map here, and again, I'm bringing up this Medeiros Weinreb study, where patients who had a high hysteresis really had a lower risk of progressing. And this guy is way over in left field, if you will, in terms of risk. His risk of having any visual field loss is like between 0 and possibly he could lose a decibel over a year or so. What do we call this? Call this definitely ocular hypertension. Then we get to the question, does this patient need to be treated? And I would argue probably not. This might be someone where you just let them have that pressure of 26 and don't treat. You didn't get much out of your drug anyway. No need for them to be at 21. There are a lot of options there. It's true that patients don't love to be taken off drops that they've been on, and you kind of need to have that conversation with them. They might feel comfortable being on the drops. It's tough sometimes if patients are scared to have a high pressure because of their previous experience. But Paul Singh stopped the drop. watched them, everything's been stable. So, using hysteresis to get confidence to really improve the quality of life for a patient, take them off their drop. Gus Gazzard here with, of course, the LIGHT study, senior author, presenting a case here of progressive normal tension glaucoma with low corneal hysteresis. And patient was diagnosed in 2011 and referred 9 years later for second opinion. Rapid progression. Goldman pressures max for 17, given Lumigan monotherapy 4 to 6 years, and Goldman 16 when Dr. Gazzard meets the patient, and IOPcc is 20 and hysteresis is 6.2. So again, you're just seeing a low hysteresis in this patient, and a high corneal compensated intraocular pressure agrees somewhat with the corneal thickness, and patient's 20/20 and all that. So he adds some medications. I'm assuming the IOPcc is is a timolol agent from across the pond, and Azopt, that would also be known as Azarga in Europe, or as something we can't get our hands on in the United States because we don't have a fixed combination, brinzolamide and timolol maleate. And basically the patient gets their pressure down to 10 and continues to progress a little bit. So, here we are kind of getting worse and worse and worse. I guess the right eye is still doing well here, but the left is tanking. In fact, it's now almost an extinguished field. So look at that RNFL in the right eye. Left eye is still pretty healthy, although there's some temporal kind of thinning. It's a tilted disc. So he does a trab and gets a pressure of 13, gets the pressure down to 4. And that does result finally in a decrease in the corneal compensated intraocular pressure, and patient is stable now. So, it's a really good example, again, of how low hysteresis was sort of a red flag. I think one of the lessons here might be, if you had hysteresis early on, you could have treated and possibly avoided surgery. And we always Monday morning quarterback, but there are lots of us who got the ocular response analyzer halfway through the clinical course of a patient and felt like, wow, I finally understand you. The reason that you've been slipping away on me is because despite these good pressures, your hysteresis is so low. And now I know I am going to add that other medicine. I am going to do that laser. It can kind of help you feel more confident to be more aggressive. I had a question here. Do you use corneal hysteresis to set a target pressure? And I certainly do. I think this would be a good example. Now, I also want to take a step back and say, I'm not one of those glaucoma specialists who goes around setting target pressures of 8 and operating on everyone. I generally think most people are going to be stable if they get to 12. 10 to 12 is sort of your dream range. 14, 15, 16, moderate glaucoma might be okay, borderline for advanced glaucoma, that type of thing. But if I see someone with a really low hysteresis, the big decisions are, yes, I'm going to treat. No, a pressure of 22 isn't okay in someone with a hysteresis of 7, even if they have mild disease, or if they have more advanced disease, kind of just knowing you now need to really kind of go as hard as you can for those low teens. So it bolsters an argument for aggressive therapy, but just on the other side of the coin, I call the high hysteresis your get out of jail free card. I have patients come in all the time loaded up on drops with a high hysteresis. I say, I'm going to take you off this drop. I'm confident you're not going to progress. The hysteresis is giving me the confidence to remove that drop that seems to be giving you meibomian gland dysfunction, dry eye, and I improve patients' quality of life by peeling off medications that are unnecessary. Okay. So, a little bit about intraocular pressure. It's usually about 15 with a standard deviation of plus or minus 3, and 21 millimeters is considered high, and 9 or below is low. all tonometers are calibrated to match Goldman because that's just how the whole system was designed. Goldman became the reference standard, and a new tonometer is being developed here to match Goldman applanation tonometry in normal corneas. I recently gave a talk on measuring intraocular pressure in the abnormal cornea, and I know the person who asked me to give the talk wanted me to talk about corneal scarring, corneal transplants, and I just talked about hysteresis because the most common abnormal cornea you're going to see in your practice is low or high hysteresis. You'll see them all day long. And, you know, we see scars, and you always kind of wonder if you're getting a good pressure after a transplant, but you know, taking care of the good normal corneas that aren't normal in your practice is probably more important. Don't adjust Goldman applanation tonometry values for corneal thickness. I know that's, you know, surprising to some of you, but the reason is because there's so much scatter. There are some people who have a real pressure that is high and have a thick cornea. You know, there's some people who have a real pressure that is low and have a thick cornea, and particularly around the corneal thickness of 550. There's all sorts of pressures you're going to see in that group. And when you use a correction nomogram for corneal thickness, you don't improve outcomes. So, you know, it's sort of a don't do it. And my EMR actually tries to do it, and I'm constantly, you know, like scraping that thing off the screen because I use Goldman applanation tonometry pressure and the corneal thickness and the corneal hysteresis, and I use the hysteresis to adjust their risk and to know that their pressure probably is a little higher than measured, but I don't put a number down because I don't think that we can say with confidence what that number would be for corneal thickness. Now, for corneal hysteresis, there is something called corneal compensated intraocular pressure that's been validated, and this is basically an adjustment of the IOPcc value, which is the Goldman correlated pressure assessment for hysteresis. And so if you want to check someone's pressure with the ocular response analyzer and use the corneal compensated measurement, you can, and it will give you a more accurate assessment. Let me give you an example. If you check someone's corneal compensated IOP and you get a number 16, and that patient goes and has LASIK, their hysteresis will likely drop, their intraocular pressure will drop, but their corneal compensated IOP will stay the same. And so corneal compensated IOP does work from that standpoint. Now, I still want to know the hysteresis because now that maybe I've adjusted the pressure for hysteresis, I still want to know if they're at high risk for their glaucoma. I still want to know what that number is. And here's the data. Very simple study showing that the Goldman pressure drops after LASIK, but that the IOPcc doesn't in this group of patients, 28 eyes pre and post LASIK. Fairly straightforward. In a population in a population of patients where you're measuring corneal thickness, as I said, you'll see that you tend to have higher pressure readings in thick corneas, but it's tough to know on an individual basis. When you use the corneal compensated IOP measurement, and this is going to come up when we talk about CATs in a moment. When you use the corneal compensated IOP measurement, you are less influenced by corneal thickness. So by taking the corneal hysteresis into account, adjusting the Goldman value, you no longer have to worry, maybe I'm just getting a high value because this gentleman has a thick cornea. You now can say, I think I'm getting as accurate a pressure as you can get regardless of their corneal thickness. So we're trying to get at real pressure here. This is kind of a complicated graph, but let me just go through it this way, which is that in theory, you could use intraocular pressure to diagnose glaucoma. Now, what do I mean by that? Well, if you could really get an accurate sense, I think you'd find that in general, patients with glaucoma do have higher pressures, and those without it have lower pressures. The problem is that with corneal thickness and hysteresis messing with all of these numbers, you end up with this red graph. And so the red graph is the pressure distribution of patients diagnosed in a clinic with glaucoma. And you see there's some very high pressures, but there's also many, many low pressures. People coming in with a pressure 16 that have glaucoma. So Goldman applanation tonometry can't be helpful in diagnosing glaucoma. However, if you use corneal compensated intraocular pressure instead of Goldman, you're going to find if you use corneal compensated intraocular pressure in your glaucoma patients, you will find higher values when they come in. And so if you had 10 patients come in, you thought they had glaucoma, you measure their Goldman, they're all 16. If you measured their corneal compensated pressure, you would see the average be higher. And in this study, on average, normal tension glaucoma patients were more like abnormal pressures, like 24, elevated. So we sort of said in our paper here that you could use corneal compensated intraocular pressure and start to pay attention to pressure again, if you will, because we kind of ignore it when we know the corneal thickness or hysteresis is off. One thing I did want to get back to is that when someone's had corneal surgery, such as LASIK, you can't use their hysteresis anymore to judge their risk. You want to know their pre-op hysteresis, not after LASIK. Additionally, cataract surgery isn't influenced. So if someone's had cataract surgery and you get a hysteresis value, you can still use that number. It's not affected by the corneal incision. And then there was a question, do I still use Goldman applanation tonometry? And I do in a couple offices, but in the few offices where we've decided to go 100% aura, I use the IOPcc and hysteresis. And so it's almost like which office I'm in. But I have no problem doing it. I make surgical decisions based on IOPcc all day long. And I find it to be, in my research at Cornell, where I compared my Goldman measures and my IOPcc, I felt like I had more confidence in my IOPcc from aura because it just, think about it. Who's going to do a better job of checking a patient's pressure? A machine or a technician who's stressed out, is frustrated because the patient's blinking, moving their head, squeezing, like all those things that, too much fluorescein in the eye, your patient's not looking in the right direction, all those things that mess with Goldman just can't affect the air jet. So I like that system very much. Okay, so I want to get to, I think I'm doing the right thing by moving us along here. I want to get to the CATS tonometer here. And Sean McCafferty is an ophthalmologist and mechanical and optical engineer. And I think at the beginning I said, I'm no engineer and I don't consider myself particularly smart. Well, he's the opposite. He is a super smart guy. And, he just had an insight that's like, phenomenal, where he said, what are the odds that the Goldman applanation tonometer tip made in I want to say 60, but I think I'm giving, too much time there. What are the odds that that tonometer tip was engineered as well as it could be? And so he just did some engineering kind of work to realize that giving the tonometer tip a biconcave surface instead of the flat one that was engineered in 1950 wasn't the best way to do it. He came up with a tip that would minimize the bending resistance from the cornea and decrease tear film adhesion, like I was saying, from things like how much fluorescein you have in the eye, things like astigmatism. And he did a study with his new tip that he invented, where he put that's a manometer you're seeing in the upper right there, to check the real pressure in the eye, the actual pressure, and compare it to his CATS tonometer and the Goldman. And of course, what he found was that, again, Goldman tonometry was very influenced by the corneal thickness, but that his CATS tonometer was independent of corneal thickness. So there's no, and it's going to sound funny, but there's no correlation between corneal thickness and IOP if you use CATS. And you don't want a correlation. I don't want my tonometer to be a pachymeter, and I joke that eye care is my favorite pachymeter because I find it to be very sensitive to corneal thickness. And I want my pachymeter to measure corneal thickness, my tonometer to measure IOP, and that's what CATS does. So, he looked at tear film and he found that that Katz's prism tear film adhesion error was significantly less than the Goldman applanation tonometry. So he had solved that problem. And then he started looking at Goldman pressure against a variety of different factors, including corneal hysteresis and central corneal thickness. And the way he does these is he basically subtracts the Goldman applanation tonometry from the Katz. And if there's no impact of corneal hysteresis on your Katz measurement, there would be, on your GAT measurement, there wouldn't be a difference between these two. But the fact that you're seeing a difference between Katz and GAT that varies across a low to high corneal hysteresis or a low to high corneal thickness indicates that the GAT is affected by hysteresis and Katz isn't, if that makes any sense. And so these plots just sort of validate that he's able to get the bias of hysteresis and corneal thickness out of his device. And ultimately, he also was able to show that you can, on average, use the Katz tonometer to check your patient. So you don't have to worry that you're now going to get these values that are all thrown off, because on average, they'll be accurate. They'll just be particularly accurate in patients with high and low corneal thickness or hysteresis. So it achieved its goal. And so the really cool thing here about Goldman and Katz is that we're sort of seeing a new tonometer tip. This is a very easy purchase. You don't need to replace the whole tonometer, just the little tip that goes on it that you can put in your practice and sort of erase hysteresis and thickness from your pressure measurements. Does it give you hysteresis value? No, you need aura for that. And so, you know, Katz and aura kind of go hand in hand. You might use the Katz tonometer tip when you measure Goldman pressure. An alternative is to use IOPcc, so you've kind of got some options there. And if you're interested in refining glaucoma risk, you can use the ocular response analyzer corneal hysteresis value and stratify patients and kind of do some of the things we were talking about in those cases above. And so, you know, ultimately, you can integrate both of these things, Katz readings, IOPcc, hysteresis, into your practice. And with greater confidence, you know, this is sort of me just kind of using the ocular response analyzer. Full disclosure, sometimes my technicians take these measurements, but the machine works in a very automated fashion. I can actually check my own hysteresis by reaching my hand around and pressing the buttons. David Taylor from Radcliffe taught me that. You know, the workflow is very good. And, you know, this is a new vital sign. It's a critical, powerful piece of information. Katz is going to help you sort of get clinically relevant pressures that are better than Goldman tonometry, and both can be brought into your practice today in a manner that's very easy to integrate. And I hope that I've helped you kind of unlock some of the confusing topics here and make it something that you could bring to clinic, you know, Monday morning. With that, I think we'll have some questions. We did get a question, first question here. Are there any concerns about COVID? And I think what you're responding to here is microaerosolization of the tear film. I do not believe so. I'll just say that. It's, you know, first of all, you know, I don't think that's the mechanism by which COVID spreads. There are 1,000 other things in the ophthalmologist's office that could potentially spread this disease. My office probably saw 10,000 patients during the pandemic in New York City. We didn't have any COVID infections amongst our staff, and we must have had, you know, probably hundreds, if not more, COVID patients without realizing it, given that we were in the epicenter of the pandemic. So I don't think that, and we used aura because we felt aura at that time was better than Goldman in terms of how close you had to get to the patient and having a technician 6 inches from the patient, so on. So not validated. So with that, you know, I tried to get to some questions. You can always talk to Dave Taylor or find me on, you know, a variety of, you know, Twitter, Nate Radcliffe, N8 Radcliffe. I'm talking about hysteresis all the time on Twitter. And thank you very much.